Welcome to our video series on how to be a good doctor. Today is ECG interpretation part 4. My name is Dr. Iresha Gunasinghe. I am a cardiologist from California. So my goal is to teach you to confidently interpret a stat ECG soon after you graduated from med school and when you're on call. And remember, you have to be methodical and you have to follow this sequence, which is rate, rhythm, axis. Then you look at the waveforms P, PR, QRS, ST, and T. So this time, let's actually do one and interpret one together. Okay, so the first thing we had to look at is the rate. So what we do is we find two QRS complexes and count the number of squares, right? So we say 300, 150, 100, 75, 60, 50. So the heart rate is around 50 beats per minute. So that's rate. Next, we look at the rhythm. Now, just to orient you, this is 1, 2, 3, AVR, AVF, V1, V2, V3, V4, V5, V6, and they have given us 3 rhythm strips. So let's just look at lead 2 because that's where you get the best P waves normally. And you certainly can see a nice P wave here, right? So, and then we are trying to look at the rhythm here. So you just eyeball and see it seems to be very regular. So we know the rate, we know the rhythm is regular. The next thing we have to check is the axis. For that, we are going to look at lead 1, 2, and 3. It's almost up, up, up. So it is normal axis. Next, we look at each waveform. We first look at the P and check to see whether it's normal in size or is there right atrial or left atrial enlargement, and it looks pretty normal. Next, we look at the PR interval, seems fine too. And then we look at the QRS complex, it's thin and nice. If it was broad, then we jump and start looking at V1 to decide is there right or left bundle branch block. But in this case, it's very thin, so we don't have to worry. Now, this is one thing I didn't share with you before. After you looked at the QRS and decided that it's normal, it's best to look at the QRS, ST, and the T together in the distribution of the arteries. So 1 and AVL usually indicates the circumflex artery. So we quickly look at QRS, ST, and T. Looks pretty normal. QRS, ST, and T looks normal. So 1 and AVL looks pretty okay. Next, we look at 2, 3, AVF together. They seem fine. It's very common to have some non-specific T wave depressions just in one lead, and it's usually lead 3. We have to mention that we don't have to worry too much because we do not see anything bad in lead 2 or 3. So now we've looked at that part. Next, we move on to the V leads. So V1 and V2 denotes the septum, right? And it looks pretty normal to me. Again, there is T wave inversion here, and you should mention that, but it's usually a normal finding. So V1, V2 looks normal. Next, we look at V3 and V4. Again, QRS, ST, and T. QRS, ST, and T looks pretty normal. And then that denotes the anterior wall. And then V5 and V6 denote the lateral wall. So we look at QRS, ST, T. QRS, ST, T. So the lateral wall is also normal. And finally, we check to see, does the QRS look really tall in V6 and the S looks really tall in V1, indicating left ventricular hypertrophy, and that's not the case here either. So as you can see, if you are methodical, you can read an ECG real quickly. Today we'll be discussing the bradycardias, and starting point for us would be the PR interval. Remember, the PR interval starts at the beginning of the P and ends at the beginning of the Q, and usually the normal is 0.12 to 0.21 or 3 to 5 small squares, right? And then in our first video, we learned about first degree heart block, where when we look at the PR interval, it was longer than 5 small squares. So we are going to build up on that theme. So this is another example for you. So this is a AV node problem where it's getting delayed. The P wave is there, which means the sinus node is working, but the message is taking longer to get through the AV node. Okay, so that's called first degree AV block. The next one is called second degree AV block, and there is two types. It's called Mobitz 1 and Mobitz 2. Okay, Mobitz 1 is also called Wenckebach. Now let's see what all these words mean. So in second degree AV block, Mobitz 1, what happens is the PR slowly gets longer and longer and longer like that, and then it drops 1 QRS complex. Okay, so that's called second degree AV block, Mobitz 1 or Wenckebach. The next kind is second degree AV block. It's Mobitz 2. What that is like it just keeps just having normal QRS complexes, and suddenly you see one P wave without a QRS complex. Okay, so Mobitz 1 and Mobitz 2. The next one is third degree AV block. What does that mean? What that means is the SA node is firing, but unfortunately the AV node is not taking that message to the ventricle. So what we see, because the SA node is working, we start seeing P waves. See this? You start seeing nice P waves, and you can march them. What that means is that they are pretty regular. Okay, they just keep happening unless they get hidden by one of these QRS complexes. And even in the top one, you can see that. So there is one P wave here, and you might get misled thinking that this QRS happened because of this P wave. That's why it's important to march them and see, is there any pattern here? And what you are seeing is the P's are marching along really regularly, but the QRS, they are also regular, but their rates are two different things. That's the easiest way to find out a third degree heart block. Now, the heart is a very smart organ, and what happens is when one guy, the big guy, starts failing because it's not getting the message through, every part of the heart is able to start its own beat. And the top chambers have faster rates than the bottom chambers. So mostly when this guy stops doing its job, it's usually somewhere up here that somebody starts working. So these rhythms are called escape rhythms. And if they are thin like this, they are coming from the top chamber. If they are fat like this, they are coming from the bottom chamber or the ventricles. Okay. So on this one, we see the atria marching along, but the rate of the atria is different from this other QRS complexes. So the ventricular rhythm is totally dissociated from the atrial rhythm. So that's third degree heart block. But this time we are going to say third degree heart block with a junctional escape. Implication is that it's a thin QRS. Compare that to this one, which is a third degree heart block with a ventricular escape. And as you can see, it's a much slower rate. Okay, so we now know first degree, second degree, and third degree heart block. Well, that's all for this one, and the next video will be a lot longer and we will discuss the rest of the arrhythmias. As I said, I sincerely hope that you'll be a wonderful doctor one day and help people in need without expecting anything in return and have all these qualities. I wish you the very best and thank you for listening. And please do take a moment to share this with your friends.